So we're going to resume with some additional talks and in perioperative space. Our next speaker is Dr. Sagar Navari, who is an assistant professor of anesthesiology at Weill Cornell, practicing cardiac anesthesiology and critical care, and he's going to give us an update on sedation in the ICU. Welcome.
All right, thank you everyone for being here. I want to go through a few things as they pertain to sedation in the ICU, and we'll kind of go through. I don't have any disclosures, but the main one is that this is not going to be a talk about delirium. I can't follow Dr. Everett and pretend to talk about that. But I do want to really focus on the evolution of what sedatives we have used, what we will maybe use in the future, different ways of thinking about how we tackle the sedation issue. Our basics will be covered first. We'll go over some current management strategies. And because this is kind of a mixed audience compared to my usual cohort of anesthesiologists, I'll go through a little bit about contingency planning, maybe principles of monitoring, some of the fundamentals of safety that was built on OR literature that we now extrapolate to the ICU. And then we'll kind of talk about what the new directions may look like. So to go from the basics, if we imagine this red line as being, a patient experiencing life in the ICU, they're mechanically ventilated, and say there's no ebbs and flows to their day, they're kept completely still, no one's bothering them, nothing else is going on. We can imagine that as maybe a flat line of noxious stimulus. And in my mind, the optimal anesthetic or sedative for this is going to cover exactly that. It'll be this gray line that perfectly covers only what needs to be covered, doesn't go above or beyond that. But the reality is that life is complicated and the ICU is complicated. And so what we really see is a typical line like this, where there's periods of no stimulation, there's periods of extreme stimulation, there's periods of doing a minor procedure, so it's almost like operating room level stimulation, and then it goes back down again. And so our sedative sometimes fails to completely match up with that completely. And so sometimes we're over-sedating patients, sometimes under, sometimes they're very uncomfortable and we're playing catch up, and now we've caught up, and now we're too caught up. The platonic ideal in my mind covers purely the noxious stimulus, nothing more and nothing less. Ideal agent would be something that would come on very quickly, come off very quickly, and it wouldn't have any metabolic variability, which is a key factor in the ICU, as we know with end organ dysfunction. So one that we can really, with precision accuracy, know when a patient is going to have that agent no longer in their system and may not be exposed to those neurocognitive issues. And then lastly, perfect drug would have no side effects or very minimal side effects. When we talk about sedation from an anesthesiologist perspective, we really talk about it in terms of, from a completely awake patient to the deepest depths of anesthesia, which we consider, in the general anesthesia spectrum. I use the word comatose because that's kind of a lay term that we use in the ICU, as well as patients and their families may use. But the extreme end of this is when patients are not responsive to invasive stimuli, they're devoid of their protective reflexes, airway or otherwise, they have depressed respiratory drive, they have cardiovascular compromise, and we have to artificially sustain some vital functions. And I think we can all agree at this point that having people in that extreme of sedation, unless there's some extreme medical necessity, is generally a bad idea. And there's been a push towards kind of thinking about sedation in objective terms that started with the ASA, defining what we consider to be, our depths of sedation. And I think most people would agree at this point that in the ICU, the ideal spot is somewhere in this minimal to moderate sedation realm where patients have some responsiveness. Ideally, their protective reflexes are not affected. They're not bothered by their clinical state, namely if they have an endotracheal intubation and mechanical ventilation, but they're maintaining the other aspects of their physiology relatively well. One thing that I always bring about is that sometimes patients are on this moderate to deep level, And if a patient is withdrawing from pain stimulation, that's not the same as a purposeful response. And so in my opinion, you're already kind of crossing into too deep, and we need to consider that again. Current management strategies, there's a number of agents that we use. I'm deliberately going to kind of bundle them in these three kind of areas, but there's other ways to think about it. Analgesics are pure pain modifiers. The classic ones we think about are mu-opioid receptors, and so both shorter, longer acting synthetic opioids like fentanyl and hydromorphone play a role in that. And then our classic, native opioid, which is morphine, which has a lot of data and safety use around it too. Local anesthetics can provide analgesia in the sense that they prevent nociceptive input at the source, which I think is something that we often overlook in the ICU because it is something that can mitigate a lot of the needs for general sedation if it's applied correctly in the right post-surgical context. There's drugs that purely work to make people look sleepy from the outside, and the word I use for this is hypnosis. It's not like a hypnotist type of hypnosis. It's really giving people the appearance of somnolence. Now, whether that means they're actually sleeping or not is a different question because EEG data will tell you that some agents very closely mimic native sleep, some don't. But external appearance of calm, peacefulness, and sleepiness sometimes is a goal that people have, especially in like agitated states. Amnestics are important as well, especially in the peri-procedural context. And that's where benzodiazepines have played a big role, and agents like propofol, which are very commonly used in the ICU too. And then there's some drugs that kind of do a little bit of all three, and the dexmedetomidine is a classical one. Ketamine is also a well-described drug that has kind of a little bit of all. And in the ideal scenario, we would sedate somebody kind of using a number of different methods, as well as a good tincture of time and some patience, as well as expectation management, both on the patient's side as well as the family side, to achieve a goal of what I think is the optimal scenario, where a patient who is able to interact as much as humanly possible, but is also not in distress or suffering unnecessarily. Agents that we've commonly used and have a lot of safety data are, these shorter acting synthetic benzodiazepines and opioids. So midazolam, primarily works as an amnestic. It's a very hemodynamically favorable drug, especially when used in isolation. It actually has a fairly good safety profile in terms of respiratory depression. It has synergy with opioids in regards to this respiratory depression, but if it's used on its own, actually can promote some degree of ongoing ventilation. The onset and offset are generally short, but in renal failure, you can get accumulation, which has a significant clinical effect we'll talk about later. Fentanyl primarily works as an analgesic via mu-opioid receptor. It has also a pretty safe hemodynamic profile, even at high doses. It does cause very significant dose-dependent respiratory depression with synergy with benzodiazepines, potentiating that even further. It is very lipid soluble, so while the onset and offset can be short at certain amounts, the effect of the drug can linger based on the pharmacokinetics and the aggregate dose that a patient gets. So if we look at these graphs, the first two on the left are looking at an effect profile of respiratory depression versus a dose of fentanyl versus buprenorphine. And we know about kind of like the plateauing effect of buprenorphine at higher doses, which is exactly why it's used in opioid dependent or withdrawal states as a way to mitigate overdose. But as you can see, is the dose-dependent relationship between fentanyl and respiratory depression is preserved. And once you get to higher and higher doses, the respiratory drive gets almost fully mitigated. There was an interesting study that was published in the BJA about taking healthy volunteers and giving them just a singular dose of fentanyl and seeing the lingering effect of respiratory repression over time. And the impressive thing is, everyone gets some initial dip, but as the doses go higher, and by the time you get to 7 mics per kilo, that effect actually stays longer. So you can see, for up to 6 hours, patients had about 50% of their native respiratory drive, and that was maintained for quite a long time. And so this is part of that kind of accumulation effect, which we may not appreciate in an ICU patient who's on an infusion for days and days and days. Propofol is commonly used. It's a very well-described and safe drug. In the right context, it can have great amnestic and hypnotic effects. It doesn't really potentiate any analgesia, so that is something that usually has to be addressed separately. It does have very significant respiratory depression, which is why it should not be used for anything short of a highly monitored setting in the hands of somebody that knows how the drug works. And they have significant hemodynamic properties. There's myocardial depression that can happen at higher doses. Propofol infusion syndrome is exceptionally rare but can be a lethal consequence. And because this drug has to be put into a lipid infusion, hypertriglyceridemia is very common. Thankfully, it has a very rapid onset and offset process. And most people that go through anesthesia training will know this paper and this graph in particular. But the fundamental concept is this: is that as you infuse a drug over time, it will, the effect site is the central nervous system. But the drug doesn't just go to the central nervous system and get eliminated that way. There's always an equipoise between the intravascular space, the target tissue, which is usually the spine and brain, and the method by which it's eliminated and the method by which it accumulates in the body. So lipid-soluble drugs will classically accumulate in this slow-release compartment of fat in the body, and slowly achieve some degree of equipoise between what's in the bloodstream, what's in the fat, and what's affecting the brain. And so at short, early doses, fentanyl will come off and come on very quickly and get eliminated in a reasonable amount of time. But over time, drugs like fentanyl that have this lipid solubility will accumulate in the fat and then start redistributing out of the fat into the central system and then affecting the central nervous system. And that can end up affecting, how much time the drug takes to effectively eliminate, even though the synthetic opioids like fentanyl don't change their actual chemical characteristic. The body's effect or the body's ability to change how it's eliminated is largely determined by this depot that's, living in your adipose tissue. Other drugs don't really have this. Propofol, alfentanil, sufentanil, and even midazolam to some degree have some degree of potentiation with time, but it's not nearly as profound as it is with something like fentanyl. And this is a problem in the ICU because people can be on infusions for rather long periods of time and they don't necessarily wake up as quickly when they're on these drugs for days and days and days. Dexmedetomidine is definitely a very popular sedative. Given a lot of safety data, it's an alpha-2 agonist. It provides some degree of analgesia and sedation. It's known to not cause respiratory depression. It has a well-described relationship with bradycardia and can cause hypotension. But there's a decent amount of literature that supports its use because it basically promotes wakefulness. It's a very light sedative in the grand scheme of things. And so it can promote a patient that's more interactive, potentially has more wherewithal about their surroundings, and potentially can mitigate some of the adverse effects that we see with deeper sedatives, namely loss of circadian rhythm and the inability to be oriented to place and time, which can complicate a lot of ICU morbidity. Some studies have shown that it can promote sleep, and nocturnal dexmedetomidine in this trial was a consistently successful measure to improve sleep as well as to improve rates of ICU delirium. But this is controversial whether this is going to bear out in large-scale data because while we do feel that dexmedetomidine promotes a more wakeful patient, which in general is a signal towards having a patient not develop delirium down the road, the relationship is not kind of fully understood from a neurologic pathway. Another thing is I always find it's interesting that even authoritative texts sometimes will say that dexmedetomidine is an alpha-2 antagonist. And even earlier in this presentation, I put that, but no one caught it. It's an agonist, and it's something that we have to always try to remember again. The Society of Critical Care Medicine released guidelines in 2018 to look over kind of what the management of pain, agitation, delirium, immobility, and sleep disruption looks like. And they've generally recommended Precedex or dexmedetomidine and propofol as first-line agents over benzodiazepines. A quick aside from the anesthesiologist perspective is that sedation monitoring should be treated in many ways like an anesthetic, because in my mind it is. It's a slow anesthetic, and so a big part of this is knowing the patient, knowing how to monitor patients well, and knowing the drugs that you're going to give as well as what their side effects are. And lastly, just having the ability to rescue if there's a problem, and we'll kind of talk about this. Namely, in the case of opioids and benzodiazepines, our rescues are naloxone and flumazenil. And naloxone, the key thing I want people to take away is that while the onset is quick, it's a very effective opioid antagonist. It does have a relatively quick offset, and depending on how long of an infusion a patient's been on or what level of dose or the type of opioid someone's gotten, they may continue to have lingering opioid effects. So redosing is expected. In the emergency room and in acute context, people know this and live it. But in the ICU, occasionally, we don't think about this immediately. And so that's kind of a key point. Flumazenil is a little bit easier to deal with because of the pharmacokinetics of midazolam being a little bit more reliable, and in general also has very high safety and efficacy. So when we think about new ways to tackle some of the problems, I want to kind of go through some of the big players that we use now, namely midazolam, fentanyl, and propofol, and try to think about what the novel agents that may or may not reflect some innovation relative to them. The hot button topic in a lot of literature now is remimazolam, which takes some of the advantages of a benzodiazepine, namely reliable amnestic properties with very minimal hemodynamic ones, but compounds it by giving you a metabolic pathway that is independent of organ function. So this drug is hydrolyzed by tissue esterases that, independent of renal function or liver function, exist and will rapidly deactivate the drug. And so this is approaching kind of that platonic ideal that I have in my mind, which is it can affect very quickly, but it'll offset very quickly. And the advantage to this in the ICU population is there because we have patients with end organ dysfunction. The rapid offset that can happen with this can be compounded with flumazenil. So if you have a patient that's not responsive or not waking up, this is like a reliable way to kind of reverse it. It was FDA approved in 2021, and interestingly, the company that makes it, which is a German company, also has their fingers in a couple of other well-known ICU-related drugs, if you can see. There's been minimal literature kind of going head-to-head with standards of care that we use, but at least in one paper, there's some thought that it can promote wakefulness and promote earlier extubation when used for sedation in comparison to propofol. But the clinical context of this is probably a little bit up for debate, because whether you extubate someone under 5 minutes or within 15 minutes really doesn't change the net effect in the ICU, because that's not really a time course that matters to us. But there is some evidence that it can work faster. The hemodynamic profile is favorable, especially compared to what we would consider the propofol standard of care. And that's not unexpected. So you can see that on the right, MAP and heart rate are preserved a lot better than they are with propofol. And you can achieve similar sedative, endpoints. There's controversy whether BIS really should be a sedative endpoint. They also use this Ramsey score as a way to assess if patients were being stimulated by noxious stimuli. And it seems like at least you can achieve similar levels with both. So it has that favorability. The problem with remimazolam is that even though it's safe and it's been used in high-risk patients, the drug costs and the net costs are a little bit complicated. A Danish study looked at this in comparison to midazolam and propofol, And effectively, it's about a 10x increase in drug costs in Danish kroners, but all equivalent, it would be about the same in dollars. The interesting thing about this paper was that they were trying to look at net costs. And the argument is that in the anesthetic context, that you may not need to have a patient monitored as closely in purely remimazolam infusion situations. And so they postulate that labor costs may be lower. But the interesting thing is they really weren't that much lower. It was a very similar total cost if you look at the bottom. And then the additional net costs of the drugs would be, still something that's going on, in your operational expenses. In the ICU, as these infusions are going for much, much longer, I think that is a rate-limiting step to us being able to use it. There's a lot of literature being recruited right now, patients being recruited into various remimazolam trials, and to see if there's benefits in terms of extubation time as well as potentially delirium and other endpoints. Propofol, we have good experience with. It has good safety, and so to iterate upon propofol is difficult. But one putative target is to take the fact that propofol needs this lipid infusion, and that emulsion ends up causing that triglyceridemia, which everyone will see at some point, as well as this potential risk, that relates to like infectious seeding of the lipid emulsion itself. So people have thought that we should use a pre-drug or pro-drug, I should say, of propofol. Fospropofol was FDA approved in 2008, and it doesn't require lipid emulsion. It's hydrophilic, and it's able to work. It gets rapidly metabolized into propofol in the circulation, and so the onset actually is slower than propofol, but then eventually it catches up and it can achieve very similar sedative profiles. The offset becomes slower too because of this kind of metabolic drag that the drug has. Theoretically, there's less pain on injection, which really doesn't matter in the ICU, but we see it in sedative contexts in the anesthesia world quite a bit. So it's safe. It seems like there was some good evidence. They've used it for bronchoscopy in one trial in the ICU with some maybe faster emergence compared to midazolam and fentanyl, but nothing head-to-head with just propofol. It is still a respiratory depressant. The issue really is that there were two problems. One is that a lot of the initial literature was industry supported, and there was a massive retraction of basically all of the pharmacokinetic papers because the assay that the pharmaceutical company gave to the researchers was incorrect. And so their concentrations, their end concentrations of propofol that they were using to determine what fospropofol would act like were fundamentally flawed. And so without knowing exactly this effect profile, it's not a great drug to use. Additionally, the net benefit and the advantage didn't seem to work out the way that people wanted, and the drug actually has been discontinued from being manufactured by the pharmaceutical company that makes it. My thought is that the net advantage that was being posited was that this drug was also going to be so safe that we don't need, intensive monitoring to look at and evaluate the side effects of, namely the respiratory depression. But it turns out it's also a really good respiratory depressant. It just works a little bit slower and lasts a little bit longer. And so the risk profile in aggregate is probably the same. In many ways, it's worse because you don't know if you've overdosed somebody until a little bit later, especially if you're taking people that are used to monitoring propofol sedation or recovering patients who have been on propofol sedation. Add to that the fact that this pharmacokinetic data was a little bit tainted, and the pharmaceutical company wasn't really finding a good market for this, and that led to its demise, so it is not there. Olceridine is an interesting innovation in the opioid space. So it's a G protein-based drug that uses still a way to stimulate the mu-opioid receptor, but it does not necessarily produce the same degree of side effects that a normal opioid would. This has been FDA approved in the last 3 years. There's a number of ongoing papers to look at the basic neurocognitive functions in comparison to morphine and other standard of care opioids that we use. The pharmacokinetics and responsiveness to noxious stimuli seem to be able to be suppressed really equivalently. The respiratory depression, notably, is about half of what equipotent doses of morphine will produce. Basically that goes with the GI side effects as well as nausea. Now, they haven't done head-to-head with fentanyl and hydromorphone, which have a little better side effect profile than morphine. But those things are coming, and this may be actually a really good analgesic adjunct for the ICU, especially with patients who get large aggregate doses over time. Another area to innovate and to consider innovation in is automation, so end organ-based, kind of serum concentration-based auto-titration of sedatives. Some people have postulated that this could really revolutionize the way that anesthesia is delivered, both in the ICU as well as non-ICU contexts. And so there was a device that was much ballyhooed and got a lot of attention and FDA approval called the Sedasys. The issue with it, namely, is that the operational costs were very high up front. And so even though there was some labor that was saved, a $200,000 machine to generate a ROI on over time was a little bit cost prohibitive. And so basically the economics didn't work out for it. Inhaled anesthetics come up every once in a while as another option, and there's an enormous amount of safety data. We know more about end organ related effects with it than we do for most every other drug. And since you can measure end tidal concentrations of these drugs, it's a really good way to tell if you're giving enough or too much or too little in a way that it's very hard to do with the intravenous ones right now. There's some evidence that because the rapid onset and offset of these drugs, they may cause patients to have a much faster wake up and extubation time. And I think that's fairly well known from the anesthesia literature, but it bears out in some critical care trials. And there's new devices that are being made to help administer these drugs in contexts where you don't have an anesthesia machine ventilator, you have one that doesn't have a vaporizer, and you have to create a mini vaporizer kind of to build into an existing ICU ventilator. So I think there's some promise to this in some contexts, certainly in like status asthmaticus or refractory seizures, there may be some use for this. Maybe people that you really don't have intravenous access or have some, really adverse reaction to some of the intravenous drugs. But long-term use in the ICU has not been studied. We don't really know how this pertains to neurocognitive outcomes, which everyone cares about. MH or malignant hyperthermia is something that's a risk factor with the volatile anesthetics, and these do cause a fair bit of hypotension. In the coronary context, there's some, anesthetic literature from the OR that discusses, this idea of like pre-ischemic conditioning that can somewhat mitigate ischemic insults, but we're not really doing that routinely in the ICU, so I'm not sure if that would really pose an advantage in this context. So, in general, thanks for your attention, but sedation is complicated. It needs to be taken seriously. It's not a flippant thing that just puts someone on sedatives to calm them down. We really need to think about why we need to sedate somebody and what's the minimally invasive, lightest possible way that we can do this in a safe manner. Because ultimately, a awake patient and a patient that's engaged with their care is a better patient in my mind, and one that generally will recover better than someone whose CNS is being depressed. The safety profiles of what we use now are really good, and they're really well described, but there's limitations, and there's issues that come with them, both from overdose and tolerance standpoint, as well as side effect profiles. Novel agents that we're looking at may have some advantages, like remimazolam's metabolic profile seems like a huge advantage over midazolam. But we still don't really know if they're going to work out in terms of not only the operational costs and net kind of financials of making any clinical intervention worthwhile, as well as really do they change outcomes in a meaningful way or not. some of these agents, we'll see what the literature shows in the next few years, but I think the promising things are looking at opioid receptors via different signaling pathways, as well as higher, more organ-independent metabolic pathways, because that will be a key winner in the ICU, because those are the consequences we deal with over and over again. And ultimately, safety is really, the key is in knowing the side effect profiles, knowing the drugs, and having some contingencies, and knowing that, look, these things can happen. We have to know how to deal with the problems. I mean, risk mitigation is the fundamental of critical care medicine in my mind, and a big part of it is taking calculated risks and making them as small as possible. All right, any questions? Thank you so much.
Thank you so much. Okay, we're going to keep moving along. Next up is Dr. Shada Taboy, also Assistant Professor of Anesthesiology at Weill Cornell, and she's going to talk about something we all dread, vasoplegia postoperatively.
All right, good morning, and thank you for this opportunity. So today I'll be discussing a complication I encounter frequently in the cardiothoracic ICU, postoperative vasoplegic syndrome. And of note, I will be discussing the off-label use of some medications. So vasoplegia is a diagnosis frequently invoked in the setting of hypotension, but it's not so easy to define because there's no universally accepted definition. The principal concept is a state of low vascular tone, and here I show the equation for systemic vascular resistance to remind us that the cardiac output is inversely proportional to the SVR. So, in a setting of an isolated SVR problem, we should expect that the cardiac output goes up to compensate. This is a key feature of vasoplegia, and it's important in distinguishing it from other conditions of hypotension. So the takeaway is that vasoplegia is a pathological state characterized by low SVR with a normal or high cardiac output in which the low SVR is resistant to catecholamines or other vasoconstricting medications and to volume expansion. The pathophysiology of vasoplegia is complex, and this figure, taken from Boosie's 2020 Critical Care Review article, highlights the interplay between multiple mechanisms affecting vasodilation. This pictorial representation from Levy's 2018 Critical Care Review article shows the pathophysiological mechanisms where we have targeted treatments. So starting at the top, at the central level, there is a neurohumoral response in which inflammatory mediators and stimulation of baro and chemoreceptors from the central nervous system, and then this triggers various downstream effects, such as norepinephrine release from sympathetic nerves, epinephrine and cortisol release from the adrenal glands, and vasopressin release, which further activates the hypothalamic pituitary adrenal axis and interacts synergistically with angiotensin II and vascular smooth muscle. Sustained activation of the sympathetic system results in high catecholamine levels for a prolonged period of time, and this, in turn, leads to adrenal receptor desensitization and hyporesponsiveness to vasopressors, otherwise known as dysautonomia. Some advocate an innovative approach using medications to avoid the sustained sympathetic surge, such as central alpha-2 agonists, and medications to downregulate peripheral outflow, such as selective beta-1 blockers. Next, there is a cellular communication that regulates vascular tone via smooth muscle contraction. The three major receptors, adrenergic, vasopressin 1, and angiotensin 1, are G-protein-coupled receptors. And during vasoplegic states, these receptors undergo a similar desensitization process. But although desensitized, we can still use medications that stimulate these receptors to induce vascular smooth muscle contraction. Finally, there is a vasodilation counterbalance that occurs at the level of the second messenger pathways. Pro-inflammatory cytokines lead to an increase in inducible nitric oxide synthase, which gives way to an excess of nitric oxide, a potent vasodilator. So we can use steroids to ameliorate the pro-inflammatory response and methylene blue to act as a nitric oxide scavenger. Now, listed here are risk factors associated with perioperative vasoplegic syndrome. The majority of perioperative vasoplegia occurs after cardiac surgery, which is where we're going to focus today. Vasoplegia is a recognized complication of cardiac surgery with a wide incidence ranging from 5 to 50%. Possible triggers include an inflammatory reaction to the bypass circuit, ischemia reperfusion injury, and operative tissue trauma. Cardiopulmonary bypass triggers a profound inflammatory reaction, leading to increased nitric oxide production, increased acidemia of vascular smooth muscle, and depletion of ATP. And at the same time, endogenous vasopressin stores are rapidly depleted, compounding the vasodilatory effect. In a meta-analysis, the only preoperative risk factor significantly associated with vasoplegia after bypass was renal failure. Although not statistically significant, diabetes and a lower left ventricular ejection fraction were also associated with vasoplegia, as are the others that are listed here. Okay. As mentioned earlier, the symptom of hypotension is not synonymous with the diagnosis of vasoplegia. We should also consider alternative explanations, including rate, rhythm, preload, and contractility. So if none of these fit, then we might have an isolated afterload issue or vasoplegia. Now, radial artery pressure monitoring is most common during cardiac surgery for convenience and patient comfort. But as a small peripheral artery, it is prone to vasoconstriction, especially when on high doses of vasopressors. And this can lead to a central to radial gradient. So, in a setting of suspected vasoplegia, it's worth considering monitoring arterial pressure in a more central artery, such as the femoral or axillary. Here is a list of treatment options for vasoplegia. In general, vasoplegia can be treated with catecholamines, such as epinephrine, norepinephrine, and dopamine. But when that is not adequate, there are many alternative or additive treatments. And while catecholamines are considered first-line therapy in vasoplegic syndrome, non-catecholamine agents should be considered, as many of these agents have less cardiotoxic side effects, and there's an emerging consensus that catecholamine-sparing treatment may lead to improved clinical outcomes after cardiopulmonary bypass. So let's review the level of evidence for these alternatives. We'll start with the highest level of evidence, randomized control trials, and first we'll look at vasopressin. Vasopressin was first examined as a treatment in sepsis with the VAST trial in 2008. The rationale for vasopressin, an endogenously released peptide hormone, is the relative vasopressin deficiency found in patients with septic shock. Exogenous administration could, in theory, restore vascular tone and reduce the need for catecholamines. In the VAST trial, patients in septic shock on a minimum of 5 mics per minute of norepi were randomized to either vasopressin or norepi with open-label additional vasopressors. Now, there was no difference between the groups in 28 or 90-day mortality or serious adverse events. But the study did generate buzz because the mortality rate was lower in the vasopressin group in the stratum of patients with less severe septic shock. Now, the follow-up VANISH trial in 2016, which used higher doses of vasopressin earlier on to see if it would improve kidney outcomes, similarly did not show a difference in these endpoints. In 2017, a randomized control trial was performed in cardiac surgery patients, and the rationale was similar. They defined vasoplegia as a MAP less than 65 resistant to fluids of at least 1 liter in the setting of a cardiac index greater than 2.2. And the primary endpoint was a composite of mortality and severe morbidity. They found that patients in the vasopressin group had a lower incidence of the primary outcome, as seen in this Kaplan-Meier curve. But when we look closer at these results, we see that the sole driver of this outcome was limited to a lower rate of acute renal failure, with a very strong p-value of less than 0.0001 and an odds ratio of 0.26. Of note, in the secondary outcomes, atrial fibrillation was significantly lower in the vaso group. Next up is angiotensin II, introduced in the AthosIII trial published in 2017. Now, patients in this study had a variety of causes of vasoplegia. About 80% of those patients had septic shock, and only a minority of these patients, about 6%, were post-op. 344 patients on more than 0.2 mics per kg per minute of norepi were randomized, and the primary endpoint was MAP response 3 hours after initiation, greater than 10, or reaching a MAP of 75 without an increase in other vasopressors. Now, a criticism of the study was that many of the patients were included that had a baseline MAP between 55 and 70. In fact, the median baseline MAP was 66 in all patients, and only a third were less than 65 at baseline. The AT2 group was far more likely to reach the target MAP of 75 and to achieve the endpoint of vasopressor reduction. However, about a third of the AT2 patients never reached the goal endpoint at all. The study, which was not powered to detect mortality differences, did not show a benefit in 7 or 28-day mortality. So although the study didn't report an increase in thrombotic risk when various types of thromboses were examined separately, the FDA package insert reports an increase in the combination of venous plus arterial thrombotic events based on this trial data. And the study was also very important because it was the sole basis for the subsequent FDA approval of the drug. Shown here is the dosing regimen used in the study. Next up is vitamin C, which we get in our diet because we can't synthesize it. Also known as ascorbic acid, it's an important cofactor in the generation of endogenous catecholamines. It's known to scavenge free radicals, downregulate pro-inflammatory mediators, and enhance vasopressor receptor sensitivity. And for these reasons, vitamin C has been suggested as a treatment for vasoplegia. Now, this retrospective before and after study generated a lot of buzz because the treatment group had a dramatically improved observed over expected mortality. So here's the rationale. Critically ill patients have either low or undetectable levels of vitamin C, and in experimental models of sepsis, vitamin C limited the damage from sepsis by multiple mechanisms. So vitamin C and hydrocortisone act synergistically, and thiamine deficiency, which is also common in septic patients, is associated with an increased risk of death. So this study suggested that the early use of IV vitamin C, together with corticosteroids and thiamine, are effective in preventing acute kidney injury and progressive organ dysfunction, and in reducing mortality of patients with septic shock. And the reason I mention acute kidney injury is because there is a theoretical risk of high-dose vitamin C precipitating acute renal failure through oxalate crystal deposition. Capitalizing on the initial excitement, the Citrus-Ali trial was published in 2019. It's a randomized control trial that looked at whether IV vitamin C reduced SOFA scores or biomarkers of inflammation and vascular injury in patients with sepsis and ARDS. Although it was a negative trial, there was a remarkable reduction in the 28-day all-cause mortality rate among the patients receiving vitamin C, 29.8% in the treatment group versus 46.3% in the placebo group. Now, the authors cautioned that the observed mortality reduction must be considered exploratory because it didn't account for multiple comparisons. The study did, however, prompt further investigation. And the recently published vitamins trial administered vitamin C again as part of a hat cocktail in a prospective randomized trial. The objective was to determine whether the hat cocktail versus hydrocortisone alone improved time alive and free of vasopressors in septic shock patients. Like the original before and after trial, the effects of vitamin C and thiamine were not assessed separately. And there were many limitations to this trial that I don't have time to go into right now, but they were not able to detect a difference between the groups in time on vasopressors, 28 or 90-day mortality, or length of stay. Thus, it seems less likely that vitamin C is a panacea in septic shock. And based on the available evidence, the latest 2021 guidelines recommend against using IV vitamin C for adults with sepsis or septic shock. In this pilot study, vitamin C was considered in patients with post-cardiac surgery vasoplegia. The study was not powered to detect the effect of high-dose vitamin C, but they did show that such a study was feasible and appeared safe. In this case, they did not achieve statistically faster resolution of vasoplegia, but a well-powered study is still needed to make this determination. Next up, we have drugs supported by retrospective analysis. And in this category, we'll discuss methylene blue. Although there are small randomized control trials looking at methylene blue in post-cardiac surgery vasoplegia, the larger studies are retrospective. So methylene blue acts in several ways to reduce vasodilation. First, it scavenges nitric oxide, making it less available for smooth muscle relaxation. It also inhibits guanylate cyclase, thereby reducing cyclic GMP, and it also inhibits nitric oxide synthase. So overall, the signal in the literature indicates that methylene blue can ameliorate hypotension after cardiopulmonary bypass, especially if administered early in the shock course. The typical doses used are 1 to 2 mg per kg, usually given over 10 minutes. Now, methylene blue may seem innocuous, but it's important to be aware of some of the potential side effects. So first, it causes erroneous readings in the pulse oximeter, although this is a transient effect. Next, methylene blue is a monoamine oxidase inhibitor, and this means that there are susceptible patients, including those taking SSRI medications, that may be at risk for serotonin syndrome. Methylene blue is reduced in red blood cells to leukomethylene blue, which requires NADPH. So patients with G6PD deficiency who lack adequate NADPH may have hemolysis if given methylene blue. Additionally, the acute reduction of nitric oxide may lead to an increase in pulmonary vascular resistance, and so it should be used with caution in patients with pulmonary hypertension or right heart failure. So now we are down to case reports, and in the interest of time, I will only review hydroxycobalamin, as terlipressin, which is a long-acting vasopressin analog, isn't available in the US. So hydroxycobalamin, which is commonly known as vitamin B12, only carries FDA approval for use in cyanide toxicity. And in those studies, only relatively mild side effects were noted. Cobalamines, including hydroxycobalamin, are potent direct inhibitors and binders of nitric oxide, and likely function as direct inhibitors of nitric oxide synthase as well. So hydroxycobalamin seems to have a dual effect on the nitric oxide mediated component of vasoplegia. It also directly binds to the sulfide of hydrogen sulfide, which acts as an endogenous vasodilator, thereby increasing its elimination. Now, the most common side effects are chromaturia and discoloration of body fluids, usually a dark orange or red discoloration. Other common side effects are shown here: erythema, rash, headache, photosensitivity, and hypertension, which is why people have used it for vasoplegia. It also causes some lab inaccuracies, which are listed here. Of note, due to its color, it has been known to cause erroneous blood leak alarms during renal replacement therapy, which will cause the machine to stop. So please be aware for those of your patients that are on dialysis. Now, case reports have described the use of vitamin B12 at various doses. For example, smaller boluses of 125 to 250 milligrams, followed by an infusion, have been used during liver transplant surgeries, and a 5 to 10 gram load over 15 minutes has been used in cardiac surgery. 5 grams over 15 minutes was the most common dosing regimen in the literature. However, there are no dose-response studies to guide this therapy. And also, it's quite expensive at around $1,000 per kit at my institution. So, lastly, I want to acknowledge something for which we actually have no evidence but frequently use anyway, and that is corticosteroids. So steroids have been used and studied extensively in cardiac surgery as an anti-inflammatory therapy. 56 RCTs from 1977 to 2015 were reviewed in a meta-analysis, and the pooled data included more than 16,000 patients and found no difference in mortality, but there were more frequent myocardial infarctions in the steroid group. They also noted a lower rate of new-onset AFib, but that was only in the smaller trials. And interestingly, the rate of wound complications was similar in both groups. So approximately 11,000 of the total 16,000 patients came from 2 large high-quality RCTs, SIRS and DEX. And these larger trials highly influenced the results of the meta-analysis and likely reflect the true effect. Corticosteroids are intuitively attractive because of the assumption that the hypothalamic pituitary adrenal axis may be suppressed in periods of critical illness. Now, steroids have been extensively studied in septic shock, and I'll remind you that the well-known 2008 Corticus trial did show faster reversal of shock, but no mortality benefit, whereas the 2018 Approaches trial showed a 90-day all-cause mortality benefit for patients who received both hydrocortisone and fludrocortisone. However, the use of corticosteroids for treatment of non-septic vasoplegic shock has not been explicitly evaluated. RCTs in cardiac surgery, including DEX and SIRS, did not use vasoplegia as an endpoint, but neither showed a benefit in cardiac surgery. This is an editorial in the Journal of Cardiothoracic and Vascular Anesthesia, which suggested the algorithm shown here. It brings together all of these treatments, taking into account various indications and contraindications to find the right time and place for their use. And this is a slightly simplified algorithm from the 2020 Critical Care Review article. Now, these algorithms may or may not be the right approach, but they do highlight the fact that treatment of vasoplegia remains complex with a lot of room for further investigation. A search of clinicaltrials.gov last month for vasoplegia and cardiac surgery revealed several studies relevant to cardiac surgery. So perhaps more evidence will give us stronger direction in the future. So I want to thank you for your attention and lots of references.
Thank you so much. That was great. Really appreciated you reviewing all of that. And we have one more talk. I know that we're going to run in a little bit until the lunch hour, but it's a long lunch break, so you'll have time to listen. We have Olga Rosenthal, who's going to be talking to us about pre-op anemia management, something a lot of us are trying to find a way into, and it's pretty complicated. So thanks for breaking it down for us.
Thank you for that introduction. So today I will be talking to you predominantly about pre-op anemia diagnosis and management, really pointing out the challenges that we've all experienced as well as the misconceptions that are important to understand in order to ultimately be able to help advance care for our patients. I think something very important to keep in mind throughout this talk is that we need to start looking at blood as a liquid organ, just like we consider optimizing other organs, function of other organs, for example, such as the heart, the kidney, and that's very, very important. So you want to think about preserving your blood and maintaining blood health. Blood transfusions can certainly be critical and life-saving facet of cardiothoracic surgery, especially in high acuity settings. However, there are always situations in which patients are chronically anemic, stable, and the benefits of giving blood transfusions in those situations really remain uncertain. And it is quite a costly intervention, as I will show you. So it is important to really be able to optimize each patient's reserves as much as we possibly can prior to elective surgery. I have no disclosures. So anemia really is a global disease that's linked to a number of different poor outcomes related to many different organ systems. It also increases the risk of infection, increases the risk of formation of blood clots, and ultimately morbidity and mortality. Anemia is oftentimes temporarily corrected, as we're all familiar with red cell transfusions. But while red cell transfusions do provide symptomatic support, they are definitely not a definitive treatment for anemia. And what I want you to be able to, hopefully I can convince you by the end of this talk, is that anemia is highly preventable. And the treatment is certainly feasible within even a short period of time, as time is clearly of the essence in cardiac surgery. So the paradoxical thing is that both anemia and red cell transfusions increase morbidity and mortality. I already went over some of the risks for anemia. With regard to red cell transfusions, there's always, of course, a risk of reactions such as your febrile non-hemolytic reactions, and worse, your allergic or acute hemolytic reactions. Among the leading causes of transfusion-related mortality include transfusion-associated circulatory overload, as well as transfusion-related acute lung injury as well. So I think a lot of us are accustomed to thinking, well, if we give a lot of blood, that's a situation in which we get to a state of achieving higher morbidity and mortality. However, that is not the case. Even with giving one single unit of transfusion within the context of the patient's surgical admission, that already contributes to a much higher risk of morbidity and mortality. This is a study from the STS database that basically demonstrated that about 10% of patients who underwent isolated CABG or AVRs received just one unit of red cells. And as a result, you can see their risk of mortality, stroke, infections, prolonged intubation, dialysis, risk of reoperations all went up. And that was the case for isolated CABGs as well as AVRs. And in the context of this study, about 39% of patients received any transfusion, and let's say a quarter of those patients were given only one red cell. So it's actually a pretty prevalent issue. And not surprisingly, cardiac surgery really has the highest transfusion rates. I outline here CABGs, which are second only to valves in the study. Of about half the patients get red cells. And if you look through the literature, about 20 to 40% of cardiac surgical patients do have anemia prior to surgery. And one of the things that does contribute to a high risk of transfusion during cardiac surgery is not just having anemia, but also the fact that some of our patients are on P2Y12 inhibitors. We do administer high-dose anticoagulation, and there is a component of consumptive coagulopathy as well as dilutional anemia that's related to the bypass process itself. So what are some of the causes of preoperative anemia? And there are many. So just to mention, 3.6 billion people worldwide are anemic. The most common cause is iron deficiency anemia. It affects about a third of those patients, and up to 80% of anemic patients that are going to undergo cardiac surgery do have iron deficiency anemia. And what's even more interesting is the prevalence of iron deficiency in general, with or without anemia, is at least double the prevalence of iron deficiency anemia that I mentioned here, but it's pretty tough to quantify. The causes of iron deficiency anemia would include menstruation, childbirth trauma, dietary restrictions, and of course chronic GI losses and possibly hemolysis. Another type of anemia is anemia of inflammation. As you can see, it's tied to a number of different diseases, some of which include heart failure, which a lot of our patients have, as well as chronic kidney disease and chronic lung diseases, cancers, IBD. The pathophysiology is quite complex and multifactorial, so it is a state of functional iron deficiency. So what that means is the iron is there but retains in macrophages, so it's not really available for use. The other factor that contributes to anemia of inflammation would be a reduction in the half-life of red blood cells. There's inadequate production of erythropoietin, which is important for stimulating progenitor production. And there's also impaired responsiveness of these progenitor cells to erythropoietin. I think these are the third thing I want to mention, and much less common, would be nutritional deficiencies, especially since a lot of our foods like bread are fortified with folate. But it's something to keep in mind. Vitamin B12 and as well as some medications are also associated with anemia. And as I mentioned, iron deficiency is very, very common. And just because a patient is not anemic, it doesn't mean that the fact that they're iron deficient is not important. This study basically was able to show that iron deficiency, whether it's in the presence or absence of anemia, is associated with a higher risk of 90-day mortality, serious adverse events, as well as major adverse cardiac and cerebrovascular events. So it's really, really important to keep in mind that even if we have our patients, if we do notice that they are iron deficient, even before they become anemic, it is still important to consider treating it. So now we're going to shift and talk a little bit more about screening for anemia and iron deficiency. So the screen is going to, of course, consist of hemoglobin, as well as looking at levels of ferritin, transferrin saturation. And I'm just going to go to the next slide just to show you just to remind everybody how we distinguish between the different types of anemia. So iron deficiency versus anemia of inflammation or chronic disease. They both have low iron levels. The transferrin is very important as it is elevated in iron deficiency, but not in anemia of chronic disease. And then transferrin saturation may be reduced in both, but ferritin is also another important one as it is reduced in iron deficiency, but may be normal to elevated in anemia of chronic disease. So once we're able to, and then we also examine things like your BMP, you'll examine your creatinine to determine if patients have any acute kidney injury, vitamin B12, folate. Once we've examined all those things and we determined that the patient has some degree of anemia, we can move on to treatment. Anemia by the World Health Organization is defined as less than 12 in women and 13 in men. The most current recommendation is that we use IV iron over oral, and I'm going to explain why that's the case in subsequent slides. And then if there is a very severe case of anemia or some component of anemia of chronic disease, we should consider using erythropoietin, which I will also discuss. So now we're going to go into iron formulations. So classically, the most common first-line treatment would be oral iron. The problem with oral iron is that it is poorly tolerated, so many times people have significant GI side effects. And it really takes at least 6 weeks to work to really adequately replete your iron stores. The good thing is it is inexpensive and readily available. There are actually newer oral iron formulations coming in the pipeline, something called sucrosomial iron. It differs from the other formulation. It has a phospholipid bilayer, which improves its bioavailability, so it should, in theory, be able to work faster than the current formulations of oral iron that we have, and with fewer side effects. However, more studies still need to be done before we use that routinely for patient care, and it is not available in many countries yet. So now we're going to move on to IV iron. So right now it's really known as the fastest alternative, and it can really achieve a hemoglobin response within 2 to 4 weeks, so much better than over 6 weeks. So here I'm showing you in the chart, there's a number of different IV iron formulations. All of them have in common that they have a iron polynuclear core that's surrounded by a carbohydrate shell. And the importance of that shell is it really controls how quickly the free iron is released from the compounds so that we don't have uncontrolled release and side effects. And the iron formulations with very low labile iron content, meaning that it is not released very quickly, are going to be your low molecular weight iron, and then these other two in the down here, your diacylmaltose and carboxymaltose. All of them can be administered in basically one sitting, called a total dose infusion, which, as you can tell, is much more convenient for both the patient and the surgeon and can get the patient to where they need to be faster. All of these formulations that are up here are all effective and safe. The difference is, of course, price. As you can see, some of the ones that are administered only in one sitting are quite expensive. And then the other thing is, of course, that goes along with expense would be insurance, whether or not they'll have insurance authorization for some of these more expensive ones. And then in terms of how much iron do we give, there are some studies that just give a gram and then reassess. They'll reassess the hemoglobin, reassess the iron studies. But there is a formula available based on what your target hemoglobin is, as well as a patient's body weight and storage iron that can allow for a more precise calculation. So there was a period of time where IV iron formulations were not popular because of the risk of allergic reactions and in general bad adverse reactions. That was attributed to high molecular weight iron dextran, and that is no longer on the market. And most of the reactions that we have to other formulations of iron are really self-limited. And they're really related, again, to how quickly that labile iron is being released from that carbohydrate shell. And these include symptoms such as flushing, chest tightness, myalgias, oftentimes without shortness of breath, oftentimes without edema. And these are all self-limited, and they just require a short period of monitoring. So just to compare the timeline of oral iron versus IV iron, so what I want you to keep in mind is that if we use IV iron, we can get the patients to surgery about 3 weeks sooner than with oral iron. And that accounts for essentially what we call an adequate hemoglobin response would be an increase of about 2 grams per deciliter over the course of those 3 weeks. So that's pretty significant. So we really want to get to a place where patients are able to get their IV iron if they need it. The other thing I want to talk about is another form of treatment called erythropoietin stimulating agents. So with certain conditions, as I mentioned, such as severe anemia or anemia of chronic inflammation, iron repletion alone will not be enough to get you there. So you do need to stimulate an increased production of your red cell mass, and you do need these ESAs. So the problem with routine ESA use has been concern for increased risk of thrombosis and subsequently mortality. However, there have been studies that suggested that this risk is really modulated by only giving brief courses, not picking a hemoglobin target such as 15, something that's a little bit more physiological in terms of thinking about dosing, and then also use of pharmacological venous thromboembolism prophylaxis, which many of our patients are still on. And so this really needs to be considered on a case-by-case basis. For example, if someone has uncontrolled hypertension, they've had any recent coronary or cerebral ischemic events, perhaps they may not be the optimal patient to give ESAs to, but I will say that there was a recent randomized control trial in patients presenting for elective surgery, 50% of which were cabbages, and they received a single high dose of erythropoietin without incurring any adverse events. So I think that's definitely a positive. And then in terms of dosing, the recommendation I've seen in papers would be about 600 units per kilo, can be administered weekly, at least for 3 weeks before surgery. But as I said, there are some ultra short-term studies that even just give 1 dose and see a pretty significant positive response. That's what I'll share with you next. Does preoperative anemia therapy even work? And the short answer is yes. The patients in the treatment group they achieve a higher hemoglobin concentration and reticulocyte count. This data is from the study that I mentioned on the prior slide. It is ultra short-term therapy prior to elective cardiac surgery. So patients were essentially evaluated either on the day of surgery or on the Friday before the Monday. So essentially right before surgery, and they were given a slow infusion of one of those total dose infusion formulations of IV iron that I mentioned that you can get away with just giving one, and then 40,000 units of subcutaneous erythropoietin as well as B12 and folic acid. And even in that short period of time, they were able to achieve a pretty significant response. The other thing they looked at is, so beyond just achieving hemoglobin, are there any important measurable outcomes that are affected? So the first thing that this study really looked at is, does it reduce their red cell transfusions? And the answer is yes. So even given in the short term, there were fewer transfusions in the first 7 days and even up to post-op day 90. And they stratified this by looking at patients who received 1 versus 5, 2, 3, 4, 5 red cell transfusions. And even though you can't necessarily see the effects consistently across all 4, you definitely see that there's way less transfusions in general, and way less patients getting things like more than 5 transfusions. They did a very, very limited cost analysis as well in this study, where they showed that because you're giving less red cell transfusions, you have less acquisition costs attributed to that, just because you have avoided transfusions. But they did mention that the cost of giving patients B12 and folate does add to cost. So they, in their conclusion, concluded that there was ultimately more costs in the treatment group. But I will go into why that's a bit of a short-sighted conclusion, and I think it's very, very limited. The reason is your acquisition costs of red cell transfusions, which really include your processing steps in the blood bank, your overhead costs, consumables, your pre-transfusion testing, your consent, all of those processes is about $761 per red cell transfusion in the United States. However, if you avoid giving red cell transfusions, it's not as simple as we just save $760. Because it leads to improved outcomes, you really, most of these studies that don't account for that, they underestimate the true cost. And I will show you some data in upcoming slides for that. So in the field of cardiac surgery, there are some additional studies that look beyond just, are we improving hemoglobin? Are we decreasing red cell transfusion? What about other outcomes, such as your major adverse events, renal failure, et cetera? And these are small studies. Granted, they are retrospective cohort studies, but I do think that they're quite promising in showing improved outcomes. So as I mentioned, renal failure, in-hospital mortality, ICU and hospital length of stay, as well as infection risk. All of these things are tied to sparing patients transfusions and appropriate preoperative anemia therapy. So what kind of a recommendation, according to our most recent guidelines, is there for doing this? So in 2021, the SCS, in conjunction with the Society for Cardiac Anesthesia, the American Society for Extracorporeal Technology, as well as the Society for Advancement of Blood Management, all came up with the most recent guidelines. And they gave this management a Class 2A, so moderate level of evidence, level B with some positive evidence from randomized controlled trials. So clearly, this is something we should be doing. And this is something we should be doing in all patients, and if it is reasonable to give the IV iron, it is recommended. I think a common misconception is that we should be thinking about it in patients who are only high risk for post-op anemia, or let's say are Jehovah's Witnesses, but we really should be doing it in all patients. And they do mention this in their recommendation as well, for the patients who are especially high risk to consider doing ESA treatments prior to that. So many surgeons and anesthesiologists agree that we definitely should be treating anemia, but the problem is it is oftentimes really an afterthought initiative in many institutions, and I want to go over some of the barriers and the reason why that's the case. So first and foremost, number one is culture. So there's a lot of fragmented care across different health systems, and it is difficult to pinpoint who would take ownership over optimizing anemia. Is it the anesthesiologist? Is it the surgeon? Is it an internist? So I think because of that, that's definitely impeded it. And there's also the misperception that anemia can safely be corrected with red cell transfusions, which is certainly not the case, as I've showed you. Education is another thing to consider. There are certainly knowledge gaps regarding anemia etiology and treatment, and that's why it's important to educate all of us about how to do that. And also, not just our education, patient education. If we can empower patients to be able to understand that this is something very important for their health, they will be able to seek it out as well. Inadequate measurement or ineffective screening goes hand in hand with one of the barriers. And then many times we're seeing these patients like the day before, a few days before, and there's just not enough time to get all the iron studies done and then treat them. And then, of course, optimization time, as I mentioned, but as I said, IV iron can be given, is effective within 3 weeks, and as these studies showed, even within days, so some is better than none. And then resources, getting your institutional resources to really be on board with funding, with leveraging the EMR, creating structured pathways, and providing an upfront investment for a clinic. And then I think even more so, a greater appreciation for the barriers comes from really understanding who are all the stakeholders. So we can go through a few of these. And once you understand where each stakeholder is coming from, and then you can think about educating everybody about that the benefits of treatment really outweigh the risks. So for the patients have to incur insurance copays, they have to come to clinic more often, they may have side effects. It's possible their procedure may be delayed. And these are all potential negatives and why patients may be resistant. However, explaining to patients that they may have a very improved quality of life and really, and that the treatment really decreases their risk of adverse events could help counterbalance that. For the perspective of the surgeons may certainly, especially with cardiac surgery, because we really need to be getting those surgeries done sooner, will be more resistant to deferring scheduled procedures, incurring costs of arranging for testing and treatment. There's also the possibility that if you wait too long to do the surgery, maybe the patient's outcomes may be worse. So these are all things to keep in mind. However, very recently, surgical pathways have been, there have been recommendations about anemia screening and treatment. So the surgery side is also coming around to this possibility. And I think as more and more time goes on, and as we show that the pre-op anemia treatment is quite effective, there will be more of a paradigm shift. And the last thing I want to mention is the hospital. So the costs of the costs to the hospital of starting up the pre-op anemia clinic, of maintaining it, can sometimes be tough to justify. But as I'll explain to you in subsequent slides, these costs are nothing compared to the cost savings associated with better outcomes. So I pose this question to you, are we being short-sighted in considering all the upfront costs, but not all of the possible cost savings later on, as patients will not have such high acuity hospitalizations, and post-hospitalization care will not be as bad if they have less complicated stays. So what I want to mention here is that there are some cost studies that were not done in cardiac surgery, but in colorectal surgery, that have basically shown that pre-op anemia is indeed cost-effective. Cost-effectiveness just means that they looked at the cost of the hospital admission, but they also factored in the cost of screening. But as you can see, in all these different models, in the end, we end up saving with screening more patients, and we end up saving by giving less red cell transfusions. And then another study, basically, again, retrospective cohort study that looked at a cohort prior to institution of a pre-op anemia clinic and post, and they were able to show that not only are we giving less red cells, but the hospital length of stay is decreasing as more and more time goes on. The hospital costs are decreasing, but reimbursements are actually staying similar from the perspective of cost. So net cost is less with treatment of anemia. And something to keep in mind is one way to generate revenue is through these IV iron infusions. So even though the cost may be pretty significant of starting up the clinic and maintaining, the revenue is quite significant. In a New York City program, they suggested that in a 7-month period, they were able to make revenue of over $350,000 just from IV iron infusions. So definitely justifies that. So just in conclusion, it's really, really important to think of the blood, as I mentioned, as a liquid organ and something that needs to be optimized just like all of the other diseases, cardiac, diabetes, pulmonary. And getting hospitals on board with investing in preoperative anemia programs is very important, and the way to do that is just to focus on the fact that we will have better outcomes. We can empower our patients to be able to seek this management if they know that they're anemic through better educational pathways. And then ultimately, once we figure this out for pathways for preoperative anemia, we can use similar concepts for post-op and perioperative anemia as well. Thank you very much.
Thank you to all of our speakers. Are there any questions? No, standing between you and lunch. Well, we have a lot of other exciting talks this afternoon. There's going to be some really great ultrasound-focused talks that I think will be really useful, both about analgesia as well as diagnosis. So please come back at 1 o'clock, and we'll look forward to seeing you then.